Okay, let's start. I'm sure we're going to have more people joining us in the next 10, 15 minutes or so. Welcome, everybody. My name is Paul Cockrell. I'm a consultant nephrologist in Birmingham and president of the UK Kidney Association. It is a great pleasure to be able to chair this webinar, which is going to focus on two landmark studies for the management of patients with chronic kidney disease and indeed with related disorders across into the cardiovascular disease and other long-term condition areas. Both these papers have been led by really strong UK research teams, and we're blessed to have chief investigators from both studies presenting the headline data from the studies today. Most of you will know that these papers were published simultaneously with presentations at the American Society of Nephrology meeting around 5 weeks ago, and both have been received with great interest by the kidney community and beyond internationally. And it's a great pleasure to start with a presentation by Professor Sunil Bhandari, who's familiar to many of you who are looking in on this webinar. Sunil's a professor of nephrology based in Hull, who's done a stellar job of leading the STOP-ACEi study focused on RAS inhibition in advanced chronic kidney disease. So I'll hand over to Sunil now. We'll have around a 20-minute presentation, 10 minutes for discussions. Put your questions up in the question boxes, and we'll try and pull all those together. And then we'll move on following Sunil to focus on EMPA-Kidney. Sunil.
Oh, many thanks, Paul. And I feel old now. Everybody knows me, but never mind. I'm just going to share my screen. So hopefully you can see the slides. Yes?
Yeah, that's great, Sunil.
Great.
Thanks.
So,
great.
I'm going to present the STOP-ACEi study, and this is a really big study which is done purely in the UK. And I have to give huge thanks to all the people involved in it. These are my conflicts, and I've got no conflicts related to this study. And you'll all be aware that from the initial studies from Lewis using ACE inhibitors initially in 1989 and then angiotensin II receptor blockers, that in mild to moderate CKD, and especially in diabetic patients, that they are protective. They delay the need for end-stage kidney disease, doubling of serum creatinine. And in fact, you don't need to treat that many patients to get benefit from these. And these were 3-year studies. But then a more recent study from McGee Elnas's group demonstrated that in advanced CKD, so that's GFRs of under 30, they looked at 52 patients and over a 1-year period, and they found in all but 4 patients there was stabilization or improvement in the kidney function. And in fact, there's almost a 10 ml per minute improvement in kidney function. So that led people to think, well, what should we be doing in patients as the kidney function deteriorates? Should we continue ACE inhibitors and ARBs, or should we stop them to preserve kidney function and hence delay the need for dialysis? And this didn't really take into consideration anything about cardiovascular benefits. So really, what can we say? We know that ACE inhibitors are good. They reduce blood pressure. They slow the decline in GFR in mild to moderate kidney disease. They reduce proteinuria significantly, and they delay the progression to advanced CKDs. But what do they do when you get into advanced CKD? So we did an open label, multi-center randomized trial of 411 patients, and that was based on a power calculation with advanced and progressive CKD to find out whether or not stopping RAS inhibitors improves or stabilizes GFR at 3 years. And actually, interesting, this was funded by the NIHR and MRC. And this was one of the first studies that they were aware of in which you stop a medication in a trial, which was quite novel to them. And this just really shows you the outline of the trial. So in terms of who got into the trial, it was only adult patients with a GFR of less than 30. As I said, they had to have progressive kidney disease, so more than 2 ml drop in GFR per year. And they had to have at least 3 measures in each of those times to get that drop in GFR. Their blood pressure had to be reasonably well controlled, and clearly they had to be on an ACE or an ARB for at least 3 months and on specialist renal follow-up. So we didn't want any crash landers. Those patients who had uncontrolled blood pressure defined as greater than 160/90 were not included. Those patients on dialysis or having a kidney transplant were excluded, and those who were on active immunosuppressive therapy, because clearly that would affect the GFR. And we also exclude those who'd had a recent stroke or myocardial infarction, because it was felt in those patients they should stay on their ACE or ARB based on the cardiologist's advice. We had a total of 39 hospitals who took part, but 37 actually contributed at least one patient. And there were 205 who continued on ACE inhibitor and 206 who stopped their ACE or ARB. And our primary outcome was the least square mean GFR at 3 years. And we excluded measurements of GFR after starting renal replacement therapy, as this would skew the data. We also looked at a number of secondary outcomes in terms of end-stage kidney disease, the need for kidney replacement therapy, a composite of greater than 50% decline in GFR, end-stage kidney disease or kidney replacement therapy, and various other measures, including safety measures in particular. The other thing we also did is we stratified these patients as a pre-specified analysis in terms of whether they were diabetic, their blood pressure, taking a mean arterial pressure greater or less than 100, their age, and we picked 65 because it's a historical measure of defined as elderly, but probably not the case. As I've said to other people in our hospital, elderly is now defined as greater than 82 years of age. Whether they had significant proteinuria, so greater or less than a gram, and finally, the severity of their eGFR, greater or 15 mils per minute. So what happened during the study? So we looked at over 1,200 patients who were potentially eligible, and of that, 34% were randomized into the two groups. This just shows you what happened to the ones that were excluded and why they were excluded. Patients being not interested. Quite a few didn't give a reason, and there was several other reasons why. And overall, during the study, the majority of patients continued in the study. There was very few dropouts. You can see here initially, between baseline and follow-up, there were some more dropouts, and that was probably partly to the number of deaths there were. There was in total 42 deaths in the group, and there was a few withdrawals. So what did the baseline data show us? And this just gives you an outline of the baseline data in the two groups. The age of the patients was around about 63 years of age. 2/3 approximately were male. And there was a high level of ethnicity in terms of white. Over 80% were white in the study, which is not dissimilar to what we would see in the renal registry. In terms of diabetes, over 60% in each group did not have diabetes in this cohort. That's really important to realize. And the blood pressure actually was really well controlled, you can see here. And the median GFR was 18 mils per minute. And you can see the proteinuria levels here. Around about a median of a gram of proteinuria. In terms of what were the causes of renal disease, and this is defined as what the investigator put down as the primary cause of their renal disease. So you can see there was a significant number of patients with glomerulonephritis, hereditary disease, including polycystic kidneys, and hypertensive neuropathy, and less so with diabetes, and that's important to recognize. The other thing which is important to recognize is that this group, interestingly, when we collected the data on cardiovascular events at baseline, that this patient group didn't have a high cardiovascular burden. You can see the number of patients with heart failure only amounted to about 4%. As you'd expect, a high percentage of hypertension, but the other coronary events were very low in this group. And I think that's something to realize when we think about the results. This is just really to show you the number of medications in terms of hypertension treatments they were on, and most patients were on at least 3 medications during the study. And I put this slide in just to preempt Will's talk, because remember, this study started in 2014, so it predates the use of SGLT2 inhibitors. And you can see, if you look down carefully, that there was only 2 patients in total who were on an SGLT2 inhibitor, not unreasonably because we didn't have the data available to know about the benefits of these drugs. So just to preempt a question on that. So the first thing we want to understand is what about adherence to the treatment? And this just shows you the adherence to treatment, the number of participants in the stop and continues arm at baseline. So over 94% in both were adherent in the first 3 months. And that gradually reduced as time went on until at 36 months, the adherence was around about 87% in the stop group and about 77% in the continue group. And remember, this is representative of the point of transplantation or dialysis, because clearly the drug may be altered for those two processes. So reasonable adherence, but could be better, and clearly a difference between the two groups, but not significant. So really what you really want to see is what happened to the creatinine, sorry, the GFR from 3 months to 3 years. And this just shows you the baseline creatinine in both groups. So these are the empirical mean values in the continue group in blue and in the stop group in red. And you can see this is what happened in the continue group. So those who continued their ACE and ARB, there was a gradual decline in their GFR to 3 years. So on average, they lost probably 3 to 4 mils of GFR over the 3-year period. And again, this is what happened to those who stopped. And again, these values are censored for dialysis and transplantation. And you can see here that again, there was a gradual fall in the GFR, similar to those who continued it down to 3 years. And if we look at the estimated adjusted mean difference, it was 0.7 mils per minute. So really, there was no significant difference in the two groups, suggesting that actually stopping ACE inhibitors did not impact the deterioration in GFR over a 3-year period in these patients with advanced CKD. And this was using the MDRD4 variable equation. And what we did is we did a lot of sensitivity analysis to see whether this was similar using other equations. I'm just going to show you some data on this. So this just is showing you that we use the CKD EPI equation, which was brought in 2009. It doesn't include the 2021 equation, which takes out ethnicity, but there's very few patients who are Black in this group. So we don't think it's going to make a difference. And you can see again, if you use the CKD EPI equation or the modified MDR, the equation using 186 as the constant value, you can see there's no difference in the two groups, and the trend is exactly the same. That in fact, continuing ACE and ARBs seems to preserve kidney function, but not significantly. Basically, the New England Journal liked lots of sensitive analysis, and this is just a selection of many using what we call a flat value. So making the assumption that when your GFR dropped to 5, we've got data on 7 mils. We have various values. If you put those in to see that if that value is when they started dialysis, again, you can see no difference in the outcome. When we looked at pattern mixture models, looking at the last observation carried forward for missing values, again, no difference. And then this new joint model, which is really beyond me statistically to understand, but it's something which is now looked at to look at evidence of any difference in the outcome based on sensitivity. And again, you can see exactly the same as the primary outcome. So it's clear that the primary analysis has shown this. So what about the secondary outcomes? And clearly in the New England Journal, you won't see these p-values, but this is the patients who then end up on kidney replacement therapy or end-stage kidney disease. And you can see here that actually in those patients who continued therapy, there was less numbers of patients with a secondary outcome. You can see there 115 in the continue group versus 128. And you can see here the adjusted hazard ratio was 0.99 to 1.65. which gives you a p-value of 0.06, so almost significant, suggesting that continuing ACE or ARBs does reduce the number of secondary outcomes. And I've asked our statisticians to look at what numbers we would need to see if that significance was there. Oh, sorry, that's the same one. So what about the cardiovascular events? Which is really important in this trial. Clearly, the trial wasn't powered to look at cardiovascular events, but we collected that data. And you can see here, I've just outlined here the heart failure in the stop group, either the number of events or the number of participants having an event. There was very little difference between the stop and continue arm, but the number of events were small. And also any other cardiovascular event defined again was not small. The only thing that was different was hypertension, which you would expect that there'd be more cases of hypertension in the STOP group initially, as you can see here, 31 events versus 13 and 22 participants versus 12. I did remind you that we did do a number of pre-specified subgroup analysis. So whether they were diabetic or not, and you can see here that in this forest plot where 0 is the point of neutrality, that there's no difference in whether you're diabetic or not diabetic. You might think in type 1 diabetes, the looks of it's going in favor of STOP, but remember there was only 20 patients in total in that group, so it's difficult to make any interpretation of that. Again, looking at blood pressure, no difference. Again, looking at age, again, no difference. In fact, pushing towards slightly favor, but again, crossing the line of neutrality. Proteinuria, no difference. And finally, the severity of GFR, there was no difference compared to the primary outcome. So the last thing we looked at was mortality. And as I said to you, there was a total of 42 deaths during the study, 20 in the STOP group, 22 in the continue group. And I've just outlined the reasons for death in those groups. And again, there was no statistical difference in those two groups in the number of deaths, so no increase in mortality on stopping or continuing the drugs. Finally, we looked at safety analysis, and this is the number of participants in both groups experienced a serious adverse event, which was adjudicated initially by the PI and then by the committee. And again, if you look at the number of adverse events, and then we looked at hospitalizations, and you can see in both groups, they were equivalent. There was no difference in either the number of participants with hospitalizations or adverse events, or the number of total events between the two groups. The last thing I wanted to show you was really, people always asked is, well, what happened to these patients' blood pressure and proteinuria during the 3 years of follow-up? And what I've shown you here is the systolic blood pressure, the diastolic blood pressure, and the protein creatinine ratio throughout the study. And this is again over the total time period. And as you can see here, as you'd expect, in the STOP arm, both systolic and diastolic blood pressure were increased as a result of stopping the drug. And it took about a year to 18 months for clinicians to use other medication to get them back into their normal blood pressure range. And then after that, they were equivalent. Likewise, in proteinuria, again, in the STOP arm, there was an increase in proteinuria, which then took some time to get back to equivalence between these two studies. So something you would expect when you stop an ACE or an ARB. So really, what do I consider in this study? Well, I think our study has shown that stopping ACE inhibitors has excluded a clinically relevant improvement in GFR when you stop a RAS inhibitor in patients with advanced CKD overall, and in pre-specified subgroups by age, severity of kidney disease, diabetes, proteinuria, and blood pressure. More patients who discontinued RAS inhibitors progressed to end-stage kidney disease or required kidney replacement therapy. So therefore, a larger trial might have shown an advantage by continuing RAS inhibition. The rate of cardiovascular events and death was similar. Systolic and diastolic blood pressure and proteinuria were greater over the first year of follow-up in those randomized to stop RAS inhibitors, but there was little difference thereafter. And that probably reflects the initiation of antihypertensive agents. And finally, there's no difference, which I didn't show this data, but we also looked at quality of life and exercise capacity, and there was no difference in those who stopped or continued. And that needs further analysis. So in conclusion, discontinuing RAS inhibitors for patients with advanced and progressive CKD does not lead to a clinically relevant change in GFR or a difference in the rate of long-term decline in GFR. I think if indicated for the treatment of hypertension, proteinuria, or cardiovascular, I think RAS inhibitors should not be stopped just because of low GFR. And our trial did lack sufficient power to investigate the effect of stopping ACE inhibitors on cardiovascular events and mortality. However, I think because our trial has suggested that there's no advantage in stopping these drugs from the perspective of kidney function, there's little rationale to conduct a larger randomized trial to investigate cardiovascular safety. So I just want to thank a lot of people. You can see here all the people, the units who took part, the 37 units who took part in the trial in Northern Ireland, England, and Wales. The patients who took part in the trial, the data monitoring committee led by John Firth and Paul Callers, the cardiologist, and the independent statistician. The independent trial steering committee, which was led by Richard Haynes with Nick Selby, and particularly Christopher Allison, who was the patient representative, and one of my patients unfortunately died before the results of these trials were available. And also the trials unit, and also all the units. Thank you.
Thank you very much, Sunil. Thank you for that. That's just a wonderful overview of a really important study. We've got some questions coming in on the Q&A. Can I just start with the question from Harish, actually, which is, why weren't patients with heart failure excluded?
That's a good question. I didn't put in the, we did exclude it if you had NYH3 or 4 heart failure, but not 1 or 2. And I guess this dates back to 2014. But yeah, it's a good point, actually. We didn't think about that, and I guess, and we had John Clint, our cardiologist, on board.
Yeah, there may be. I mean, Sunil, if you think about the overall numbers of patients that were screened, but then ultimately ended up being recruited into the trial, do you want to make some comments about that? Because when one looks at the EGFR at which patients, median EGFR at which patients entered the study, there's obviously a lot of selection up until the time that those individuals get.
Absolutely.
So there may be some, there may be some investigator level selection. Have you got any particular thoughts about that?
Yeah, so probably people don't know is there's 3 types of clinicians in this when we thought about this question. Those who strongly believe that you should stop ACE inhibitors when your GFR drops to preserve kidney function, and those patients, a lot of patients would have stopped their ACE inhibitor prior, and therefore would not have been eligible for the trial. So I can make no comments on those patients who'd actually had their ACE inhibitor stopped. There's also the group of clinicians who believe that they should not stop their ACE inhibitor, so they continue their ACE inhibitor, and that might include a heart failure group and high risk cardiovascular group. And then there's those group of patients, those group of clinicians with equipoise and didn't really know what to do in this situation. So there's 2 groups of patients we can't really comment on in this study. But I think I'm not so bothered, because of those group that continue this inhibitor, that was probably a good thing from our trial in a sense. It's reaffirmed that. And hopefully it's convinced the group that have stopped it that maybe they need to think again about that group of patients. So I'm less bothered now about that.
Thanks. So there's an interesting question from Swapnil about the GFR endpoint choice. Do you want to say something about that? Was that the right choice of endpoint as opposed to renal replacement therapy start? Yeah,
again, this is something we deliberated on for a long time. And because of all the data coming out about GFR and the sort of the slope GFR changes, it would seem to be the most exciting and relevant endpoint to study. I guess in retrospect, it might have been secondary endpoints would have been nice to have in the primary endpoint, but you can always look back in retrospect and say, why didn't we do that? The perils of running a trial, you can't always get the thing right at the start. So I think, in retrospect, maybe we should have done that, but we didn't know, and clearly the secondary endpoint is pretty close to significant.
And I guess I mean, more broadly speaking, Sunil, in terms of powering the study based on a rate of decline of estimated glomerular filtration rate, and there are people who are methodologically minded on this particular webinar, that does open up the opportunity to do studies with smaller numbers of patients than have historically been the case with hard endpoints when we're looking at patients with kidney disease. And because the FDA and I think the EMA are starting to recognize rate of decline of estimated glomerular filtration rate as a robust endpoint for licensing purposes, that then brings us into perhaps a new era of doing randomized controlled trials. And certainly there's quite a number of studies which are currently in process, and a number of studies that people have seen published on in the last 2 or 3 years where that's been the end point.
Absolutely, Paul.
Okay, there's an SGLT2 inhibitor question that we've put in as answered, but I don't think we have answered. Adding SGLT2 inhibitors to ACE inhibitors in advanced CKD hyperkalemia. Let's leave that for EMPA-Kidney, because there may be something in there for EMPA-Kidney that Will can make a comment on. There's also, we didn't see a GFR bump as the RAS inhibitors were stopped. Great question. Sunil.
Yeah, so that's something everybody's commented on, and I guess what you're doing is you're looking at the mean values in those when you stop it, and so you're making the assumption that you'll get a bump in everybody, and it may be that you don't see that, and that's clearly what we see. You've got the empirical means at the start at time 0. And we thought about this a lot because of the 2 groups that it does balance out. So in a sense, you might not necessarily see a bump. You're always making that assumption you'll get recovery, but you don't always.
Thanks. We're almost done for time-wise, but just quick fire, Sunil. Why did so many patients decline to be involved? Do we have any sort of idea what the other reasons were?
No, I need to look into that. It's often they just say, no, and you're not meant to pursue that in a trial.
Okay, HB decline with ACE inhibitor or increases of HB?
So we looked at HBs and we looked at ESA use, and that data is in the paper, but there's no difference in ESA use or HBs. We expected that I thought they might increase. That's why I wanted to look at that with stopping ACE therapy, but we didn't see any difference.
And then there's a question around hyperkalemia, low rates of hyperkalemia,
so
self-select.
6 cases of hyperkalemia only, 4 in the stop in the continue arm and 2 in the stop arm. In fact, I did have a graph of that. The average potassium in the continue group was around about 5 millimoles, and in those that stopped it went down to about 4.6 millimoles, but very few cases of hyperkalemia.
Great, thanks ever so much, Sunil, for fielding those questions. And I think that the stops clocked, or the clock stopped for this particular webinar for STOP-ACE. And we're going to move across now to EMPA-Kidney, and it's a great pleasure for me to introduce Will Herrington, who's a professor at the Oxford CTSU and is one of the chief investigators on this landmark study of SGLT2 inhibition in chronic kidney disease. Will.
Thank you. Thank you, Paul. Merry Christmas, everyone. I'm afraid I'm isolating at home because I've got an upper respiratory tract infection. If I pause for a drink, I apologize, but I'll try and be clear. So, yeah, this is an enormous privilege to be presenting these data. The trial EMPA-Kidney was initiated by the Renal Studies Group at the University of Oxford. It's been designed and conducted, therefore, by the UK, essentially UK research community. We analysed the data and we reported it, but we obviously had the support of many people, and in particular, a group of experts on the steering committee from around the world. We approached the funder, Boehringer Ingelheim, and they sponsored the trial, but we also had support from the UK Medical Research Council, and importantly, I also had personal support from Kidney Research UK. And the idea for this trial was actually back in 2016. We saw the results of EMPA-Reg outcome, the renal analyses that were published in 2016, and we thought that these drugs really should be tested in people with lower levels of kidney function, because if the benefits seen in people with preserved kidney function were at least half that size, they were still going to be important. We never imagined the result we were going to get now, 8 years on, 6 years on. And then we also wanted to test the hypothesis, which we thought was a punt, which was looking at people without diabetes. And anyway, we developed the design. We convinced the funder to support a very large international trial. And in 2018, we got it registered. And so it's been a long time since the first idea to result, which is why I really sympathize with Sunil as well, with all his blood, sweat and tears developing STOP-ACE. So anyway, the broad principle of what we wanted to do was to assess the effects of an SGLT2 inhibitor in a broad range of patients. In this case, we managed to recruit 6,000 or just over 6,000 people with chronic kidney disease, and they needed to be at risk of progression, which we defined quite simply. And that was simply of having already progressed to an eGFR between 20 and 45. And that measure had to be at screening and historically at least 3 months before, or they had more preserved kidney function, but had evidence of risk of progression with at least 200 milligrams per gram of albuminuria. So that's about 24 milligrams per millimole. And we wanted to exclude wide range. We wanted to include wide ranges of people. So we exclude only those patients we were concerned about or where there was some strong biological rationale not to include them. We obviously regret this now, but we excluded patients with polycystic kidney disease and kidney transplants. There is increasing data that you can safely use these drugs in people on immunosuppression. So we would like to have studied these people if we were to redesign the trial today, but we didn't include them. Participants had to be on a clinically appropriate RAS inhibitor, provided it was indicated and not tolerated. So people who couldn't take the drug, or because it's not always indicated in people with low levels of albuminuria, they could still come into the trial as long as the investigator considered that to be a reason for them not being on the drug. And then we randomized people simply 1-to-1 to the test treatment empagliflozin 10 milligrams once daily or a matching placebo. And the plan was to follow them to at least 1,070 primary outcomes. And we had powered the trial 90% 2p equals 0.05 to detect a 18% relative risk reduction. The 18% is somewhat smaller than was seen in EMPA-Reg outcome, but we were expecting attenuated effects in people with low GFR and in people without diabetes. And the primary outcome was mainly a kidney disease progression outcome, but it was a composite combined with cardiovascular death. Kidney disease progression had a main clinical component of needing to start maintenance dialysis or receive a transplant, or dying essentially from untreated kidney failure, or eGFR components down to an eGFR less than 10, i.e. kidney failure to the extent that you would expect dialysis to need to start imminently, or an important change in eGFR of at least 40%. And these declines needed to be sustained, which meant that they were measured at consecutive study visits or at the last scheduled visit. And here are the baseline characteristics. So 6,609 patients, always balanced between the characteristics, and mean age 64 and about a third women. No prior diabetes was actually more common than diabetes. That was a deliberate recruitment strategy. We saw the results of DAPA-CKD and we were halfway through recruitment, and we were able to encourage larger numbers of patients without diabetes into the trial, which is one of the unique features of EMPA-Kidney. But another unique feature is the particularly low level of estimated GFR. We're the lowest of all of the trials that have been reported to date, 37 mils per minute on average, but with just over a third with eGFRs less than 30. And we're also, of the CKD trials, the lowest in terms of level of albuminuria, if you ignore the cardiovascular outcome trial called SCORED, with about 300 milligrams per gram. So just under a half of the patients had A1 or A2 levels of albuminuria. Obviously, 31% had diabetic kidney disease. You can work that out from this, but we had 25% with glomerular disease and 22% with ischemic and hypertensive disease, 12% with other causes, and about 10% unknown, which is about what you would expect. And this is how the consort diagram looks. So we randomized, and we were really lucky to be able to find ways to follow up patients and keep them on study treatment during the COVID-19 pandemic. The trial was actually reviewed by the Data Monitoring Committee for its single formal interim analysis in March, and they recommended we stop the trial early, and all the follow-up was complete by the 5th of July. And at that stage, the pandemic had sufficiently been controlled and vaccination was sufficiently controlled that we actually got 99% complete follow-up with really good information on creatinines measured in such a large number of patients. And by that stage, we had about 2 years median follow-up. And at the midpoint of the trial, about 12 months, we had about 90% reporting taking most of their study treatment. and with very little drop-in, which we were surprised about, less than 1%, starting an open label SGLT2 inhibitor by the end of follow-up. So the results that you'll see are effectively a good assessment of 2 years of treatment and 90% of patients taking study treatment with minimal drop-in. And these were the results. So this is the Kaplan Meier plot. 558 participants had a first primary outcome in the placebo group and 432 in the empagliflozin group. So this is a substantial reduction, a 28% highly statistically significant reduction with a confidence interval between 18 and 36%. And a Kaplan Meier plot, which you'll see looks like sort of a Big Dipper ride, a slide, but that's because we follow patients and saw them once every 6 months. So we collected creatinine data every 6 months. So you see these steps at the 6-month time points. But even by 1 year, in actual fact, if that result at 1 year, you see actually is statistically significant even at 1 year. So it's no surprise we were stopped early given the large treatment effects. Now, there were 990 primary outcomes, and this really was designed to be a kidney disease progression trial. And actually, of those patients, 888 participants had a kidney disease progression outcome. And you can see this Kaplan-Meier plot of that component of the primary on the left. And you can see there is a 29% relative risk reduction consistent with the primary, as it really drove the primary result. But we had a much lower than expected rate of cardiovascular death, perhaps because of secular trends, recruitment in large numbers in the Far East where cardiovascular mortality rates are low. Maybe some other reasons we don't fully understand, but there was a low cardiovascular death rate, and there was no significant effect on that component of the primary, but small numbers of events. Importantly, the point estimate of 16% risk reduction, although non-significant, is completely consistent with the totality of the evidence, so probably just underpowered. But if you took that cardiovascular death outcome and combined it with the hard clinical components of starting dialysis or need of a kidney transplant, then that's the fact you start to see the Kaplan-Meier plot doesn't become humps because it's not based on creatinine measures. This is based on hard clinical outcomes that could have occurred at any point during follow-up. And you can see that we stopped people needing to start dialysis or receive a kidney transplant or dying from cardiovascular death altogether, a 20% significant reduction in risk. So this isn't just changing creatinine, it's changing the risk of needing to start dialysis or kidney transplant receipt. Now, that was a very exciting result for us, but one of the next questions we really wanted to ask ourselves is, does it work in people with and without diabetes? The result from DAPA-CKD was incredibly encouraging, but does it work in a wider range of patients with lower levels of EGFR, with low levels of albuminuria? That result from DAPA-CKD was based on 128 primary outcomes. We had a lot more. Could we test the hypothesis? Is it robust? And the answer in this slide is yes, these treatments work in people with and without diabetes. So the overall result is in the diamond. The effects in the boxes and whiskers are the effects in the subgroup, but the number you really need to look at is the heterogeneity p-value. That's non-significant. So the overall result, the 28% relative risk reduction, is the best estimate of treatment effects on the primary outcome, at least in people with and without diabetes. Now, we pre-specified 2 other subgroups for main emphasis because they had stronger rationale, and we didn't want to complicate our interpretation by specifying too many subgroups. So we didn't want to essentially put ourselves at risk of multiplicity of testing. So here is the result for EGFR, which is a particularly important result in EMPA-Kidney because we have over 500 outcomes in patients with the low levels of EGFR that we see in our clinics. An important number, as I told you already, is the number at the bottom, that trend p-value of 0.78. It's non-significant, which means the overall result is the best estimate of the overall of the effect in all of these subgroups. And what's pretty remarkable is you don't even begin to see the beginnings of a trend of attenuations of effect. And I think I've popped in a post hoc analysis here. So because of EMPA-Kidney actually screened patients and then allowed them to go into a placebo run-in, and they had 6 to 15 weeks before they were actually randomized. Some of those patients with a low EGFR just above 20 when they were screened actually had an EGFR between 15 and 20 by the time they were randomized. And we had actually 254 patients like that. And in actual fact, over 100 primary outcomes in that group of patients. And you can see the overall effect is the best estimate in that treatment group as well, although somewhat limited by smaller numbers. But we're really not even beginning to identify a threshold below which SGLT2 inhibitors seem to slow kidney disease progression. So this, I think, is a remarkable result. It's definitely post hoc, but I keep showing it because I think it's actually important to help us understand that EGFR is not a modifier of effects of SGLT2 inhibitors on the kidney. And then this is the last of the 3 key subgroups we specified for emphasis, and it's by baseline level of albuminuria. Now, EMPA-Kidney was just 2 years long, and actually, people with the lowest levels of albuminuria were progressing relatively slowly. And so we have a limited number of events in those with an A1 level of albuminuria, only 84. And you can see the width of the confidence intervals is anything between the actual primary result of the trial or something much more modest. And if you look at the number at the bottom of this forest plot, the important number, the trend test, you can see that there is a trend to smaller effects at lower levels of albuminuria, or you might say larger effects at higher levels of albuminuria. And we saw this result and thought this was particularly important for the community. And we'd elected to explore it further in pre-specified analyses, which were pre-specified, but exploratory. We brought these forward for the main publication to help us interpret, is this evidence of no effect in people with low levels of albuminuria or reduced effect? And so I'm going to try and explain those to you now. So they are based on EGFR slope analyses that I think Sunil and Sunil were discussing on the chat. What you can see here is an EGFR slope. On the top, you can see that there is a rate in the placebo group, which is continuous. And then you can see in another example of a slope where there is a dip followed by a plateauing. Now, that's the classic image you see with an SGLT2 inhibitor. And we consider either the total slope from beginning to end, or in the context of where you have an acute dip, it's actually often more ideal to look at that chronic slope, as we know that a lot of that slope is reversible and the acute dip is reversible. So these have been developed. They've been developed by the US, by large collaborative meta-analyses of observational and randomized data, and in conjunction with regulators, the US and in Europe. And they are being considered for regulatory submission trials now. Even if finerenone, there's an EGFR slope analysis planned trial, which is recruiting, called FIND-CKD, which is just using this as their primary outcome. And essentially, the data tells us that an EGFR slope reduction of an absolute difference of about 0.5 to 1 mil per minute per year is highly predictive of an important slowing of kidney disease progression, perhaps around a 30% reduction in the longer term. And that's also considered clinically meaningful. So between 0.5 and 1 is thought to be the threshold for a difference in slope, which would be considered clinically meaningful. And so here is the EMPA-Kidney EGFR slope results. We've got placebo over time, and the rate of decline is 2.75 mils per minute per year. So every year, that's the rate of decline. And then this is the acute dip you can see in the pink empagliflozin allocated patients, and then the slowing of chronic decline. So they slowed to 1.37 mils per minute per year, and the difference between 2.75 and 1.37 was 1.37 mils per minute per year. So that's the absolute difference. It's larger than the 0.5 to 1 clinically meaningful result. This is an important result overall. But because this is actually quite a sensitive outcome, we can actually then look at this across people with and without albuminuria. And so this is the same way of doing the analyses. We've just simplified it. So the diamond is that result you just saw, the 1.37 mil per minute per year difference. And then you've got the results you recognize in pink and navy blue to the left. So in this case, the benefits, if empagliflozin works, is on the right-hand side of that line of null effect, not on the left, like the other forest plots. And so then let's look at the placebo group. So you can see boxed as the rate of decline every year in the different patients with different levels of albuminuria. So just under 1 mil per minute per year in people with A1 levels, increasing to 4 in those with A3 levels. And then you can see in pink the rate of decline in people allocated to empagliflozin. But most importantly, you see on the right in bold the absolute difference. So you can see that if you had A3 levels of albuminuria, you had a 1.76 mil per minute per year difference. So a really important slowing of the rate of decline. But even if you had A1 levels of albuminuria, the rate of decline was reduced from 0.89 to 1.11, so it's 0.78 difference. So it was slowed by nearly a mil per minute per year. And this would be predicted to have important effects on kidney disease progression if patients were followed up for longer term. They're only progressing at 1 mil per minute per year, and that acute dip was 2 to 3 mils. So over a 2-year trial, which didn't have time essentially for those lines to cross, but the rate of decline was slowed. And over a longer period of time, we would expect there to be important benefits. So our interpretation of the results of that subgroup analysis, which has caused a lot of attention, is that it doesn't represent evidence of no effect. It represents evidence of smaller effects, but we expect the effects to be preserved. And that's quite an important nuance of the interpretation of these data. So the world's not just about kidneys. We did pre-specify some non-kidney secondary outcomes, and here were the 3 key secondary outcomes that were controlled for multiplicity of hypothesis testing. We had a low cardiovascular event rate, so we didn't have significant effects on hospitalization for heart failure, cardiovascular death, but the result is consistent with the totality of the evidence. But we did have 3,500 hospitalizations, and interestingly, we had a 14% reduction in those risks. And that wasn't driven actually by vascular disease, that was driven across the board of different types of organ system reasons for admission. There wasn't anything which particularly stood out. And we're exploring this more in health economic analyses at the moment. And then safety. Did we learn anything new about the safety of these drugs at low levels of EGFR? Well, they cause less glycosuria. They cause very minimal effects on glycosylated hemoglobin. So I wasn't expecting to find them to be unsafe or less safe. And in natural fact, we found that they were had effects which were consistent with what we knew from other populations. So no effect on urinary tract infection. About a non-significant 17% reduction in the risk of serious hyperkalemia. Overall, we've seen results just like that from meta-analyses of other trials. So this result is non-significant but completely consistent in its point estimate with the other data. AKI, again, non-significant, but that point estimate is identical to the results from the totality of the evidence. So we just fit nicely into what's already known. And then we know that these drugs can cause ketoacidosis, but the risk is really low. Look, there's only 7 of these events in the entire trial, but it was 6 versus 1. And one of the 6 was in a patient without diabetes who got incredibly sick, and it did eventually just push them into ketoacidosis, but it was resolved very rapidly on treatment. So if you push people hard enough, if they've not got diabetes, you can induce starvation type ketoacidosis with these drugs, but you really do have to try hard. And then the effect on amputation, 28 versus 19, that's non-significant. And there's some very interesting data exploring this in a meta-analysis we published in parallel, which I'm afraid I haven't got time to go into today, but I might dip into if any of the questions are asked. So those were the conclusions. There were 6,609 patients with CKD. We have a broad range of causes, but they were identified as being people at risk of progression. I mean, particularly, although we were set out to study a broad range of patients, we particularly managed to recruit people with low levels of kidney function and low levels of albuminuria and large numbers of people without diabetes, because those are the people that had been understudied, and we were able to direct the trial to that specific population during the pause of recruitment during COVID-19. And within this population, we showed that empagliflozin safely reduced the risk of the primary outcome by 28%. And these benefits were largely consistent across people with and without diabetes, across the full ranges of EGFR studied, with absolutely no threshold appearing below which kidney benefits persist. But we did find effect modification at low levels of albuminuria. So it looks like at higher levels of albuminuria, there are larger benefits. But we've investigated this more with EGFR slope analyses, and they do suggest that empagliflozin would be expected to slow chronic EGFR decline, irrespective of your baseline level of albuminuria. So there's lots and lots of information available on our website, as well as the publication, including the meta-analysis I alluded to. Like Sunil, we were very pleased to be the UK leading It felt like the UK leading the late-breaking clinical trial presentations and New England Journal publications in Orlando. Fantastic memories for everyone. And there are some extra slides if people want to ask questions about them, but that's where I'll stop. And I'd like to stop really by saying thank you to all of the UK collaborators, if any of you are listening. I know many of you heard this talk before, but it was 50 centres, over 1,000 patients in the UK. So we represented really a very important contribution to, and what I hope is, as Paul said, a landmark study for nephrology.
Thanks so much, Will, for a wonderful presentation. I mean, there is so much there, isn't there, for people to reflect on. With my, there's one or two questions in, but I'm going to start off by stripping it back. So with my deconstructionist hat on, and you're going to shoot me down for this, we should just be offering an SGLT2 inhibitor to everybody with an eGFR of between 15 and 45, irrespective of albuminuria, and everybody with an eGFR of more than 45 who's got 22.6 milligram per millimole or more. Is that about right? Is that what the guidelines should just say? Those two lines?
I'd love the guidelines to say something like that. If these drugs were free, and the health economic analyses would obviously show them to be cost saving, massively cost saving in such a situation, then that would be the ideal situation, because I think we've shown that they benefit people for, obviously the absolute benefits will vary quite substantially by some of the characteristics, and there'll be some nuanced arguments whilst these drugs are on patent and there has to be restricted prescription. But a very simple rule of thumb is actually the EMPA-Kidney inclusion criteria would be a good way to define who should take the treatment if you've got CKD. There's actually a lot of other people who have also been shown to benefit. You mustn't forget people with heart failure, irrespective of diabetes status or ejection fraction. And you mustn't forget people with type 2 diabetes with prior cardiovascular disease or at high risk. But if you've got patients with CKD, it's a really easy rule of thumb now.
Will, you may have the meta-analysis to hand, and if you have, we'll give you a moment or two just to find the numbers needed to treat figures, which are really impressive in respect of heart failure studies and CKD and so forth. There's a lot of people who are working in clinical systems here on this particular call. Can I really encourage people just to think about your catchment areas and to just look at the numbers needed to treat that Will's going to show us now and relate it to what impact it'll have in your integrated care system, CCGs and so forth. These are hugely important numbers of people. Let's get, if Will walks us through this for a second, we can perhaps pick that thread up a bit further.
Yeah, there's about a 10-minute presentation that builds to this slide. But I'll just try and orientate you to it. But essentially what we did was we collaborated with all of the trials, but in particular with the DAPA-CKD and Credence team to derive a single definition of kidney disease progression, a single definition of acute kidney injury. And we put all the data together into a collaborative meta-analysis and looked at the effects in people with and without diabetes. And remarkably, there was no difference in people with and without diabetes in terms of the relative risk reductions. They're consistent across all of the trials. I haven't shown it to you, but it's also consistent across different causes of chronic kidney disease, including people with glomerular disease and other causes of diseases, and including people with IgA nephropathy. All of that's in the Lancet paper, which I haven't managed to tell you all about today, but I encourage people to look at it. But this is the distillation, when you get to figure 5 of that paper, of the absolute effects. So absolute effects is one way of looking at that, is numbers to needed to treat. But I like to look at that in terms of how many events you avoid when you treat 1,000 patients, and you put in a factor of time, so years. So numbers of needed to treat don't always say how many long you have to treat the patients for, but this brings in time. And you can see on this graph in navy blue is the kidney disease progressions prevented for 1,000 patients treated. So this is at least a 50% decline in EGFR or starting dialysis. So per 1,000 patients, you reduce 11 patients with CKD and diabetes. You reduce 15 patients with CKD without diabetes from needing to start. And obviously you continue this for 4, 5 years, 10 years. Obviously these numbers just continue to add up very substantially. We also reduce serious acute kidney injury That is something that these drugs do. And we should start thinking of this as a benefit and an efficacy rather than a safety outcome. And you can see the numbers there are actually quite impressive. And then if you're at risk of cardiovascular disease, we also reduce those. If you've got heart failure, then you get enormous numbers. So you get like 50 events per year prevented. There is some harms. So there is a balance of risk and harms. But you'll see on the right that the risks of ketoacidosis and lower limb amputation just don't really exist for people without diabetes. So we've got enormous benefits with almost no cost in terms of health cost. It's a cost in terms of supplying the drug and the cost of that. There is obviously some risk of ketoacidosis. There's some debated risk about amputation, but you can see from the bars that they are far outweighed by the benefits. So this is all in the Lancet paper. I hope you've got some idea on the left of the benefits in absolute terms for CKD with diabetes, and on the right, CKD without diabetes. And I'll leave that slide up, Paul, for just a little bit longer.
That's great, Will. And that actually answers 2 of the 3 questions which have come in around side effects in people with and without diabetes. The heart failure analysis, and we really have to be minded as kidney specialists that actually we're moving at the system level, of course, towards working with other long-term condition areas and working across long-term condition groups. The majority of elderly people in particular will have multiple long-term conditions where they may get additional benefit across organ systems. But just the heart failure data is astonishing, isn't it, Will? And actually the numbers in the meta-analysis, the numbers of patients who were actually protected from hospitalization with heart failure are really quite striking, but also the numbers of patients with the benefits in terms of AKI events as well.
Yes, so I'm wondering if I can switch to the AKI slide, because I've got a couple more slides. I think that's fine. We keep
going because actually we still got over 40 attendees on, and this is just such an important conversation, for us to explore.
So let me see if I can make this work. It may or may not work. We'll see. I'm going to. Oh yes, it's kind of working. So can you see that slide there, Paul?
Yeah, we got that. Great.
So we've got all of the 13 trials in the time between the data monitoring committee in March told us we were stopping early, and by the time we reported in Orlando in November to share acute kidney injury serious adverse event data by diabetes status. They nearly had all of the same definitions, but these are all so people who had developed acute kidney injury and had generally been hospitalized for it. And the overall result for that was a 23% relative risk reduction. I think we were expecting, because of the osmotic diuresis, of natriuresis, the fact you get this acute dip in EGFR, that these drugs were going to cause acute kidney injury, a bit like combining 2 RAS inhibitors, but we just don't see that. We see a 23% relative risk reduction. And it might be driven by protection of the tubules. There's lots of speculation about protection against ischemia, reperfusion, but it's a consistent effect that we see, not just in patients with CKD, but in patients with heart failure and large numbers of treatments where risk of acute kidney injury is high. And we see it consistently across people with and without diabetes. The effects are there. And it's true, I have to say, across all of the drugs that have been tested, really the kidney benefits look like a class effect. Once you standardize for the different trial outcomes, the results are almost identical for DAPA-CKD, for EMPA-Kidney, for Credence. So this is really a class effect. And then there's another bit of data. We did the same for cardiovascular death or hospitalization for heart failure. And you've now got orientated to these slides. But again, remarkably, a 23% relative risk reduction. Even larger effects on heart failure, more modest effects on cardiovascular death. And again, no difference. The only thing I would say is we've actually got relatively limited information about this outcome in people with CKD without diabetes. This diamond here in the non-diabetic population is driven largely by the heart failure trials. They're 10 times higher risk of being hospitalized for heart failure than the CKD populations that have been studied. So yeah, enormous benefits.
Great, thanks, Will. Perhaps Sunil will contribute to this one as well. So this question about, I mean, you know, it's really a transformative period for chronic kidney disease and other long-term condition management. So this question about the drugs that are protective being used in combination, and whether this is an additive benefit or whether there's a requirement. And of course, the criteria for entry into the SGLT2 inhibitor studies has included, unless the patient can't, the patient's on a RAS inhibitor at sort of optimally tolerated dose. But we've also got the mineralocorticoid receptor blocker story as well. So if you look at RAS inhibition, SGLT2 inhibition, mineralocorticoid receptor blockade, would one or both of you like to comment on combinations, and if the RAS inhibitor is contraindicated, you should still get an SGLT2 inhibitor if that drug is tolerated, etc. And perhaps extend that also to be a bit speculative as to where you think mineralocorticoid receptor blockade is going to come into this as well.
So I think really we're in a nice position at the minute. We've now got some drugs which work, and that's good. And certainly, to me, ACE inhibitor first and foremost, then an SGLT2. And I think if you can't tolerate an ACE, then an SGLT2, absolutely. And that's purely for the non-diabetic benefits. I think we're not really bothered about the hypoglycemic effects of them. And certainly, I think the new mineralocorticoid receptors look very exciting, especially for proteinuria reduction, potentially delaying GFR. There's this issue about, do they prevent fibrosis? And that's another issue, and anti-inflammatory. So I think we'll be looking at patients on an ACE, an SGLT2, an MRA, plus or minus a potassium binder to make it all work very well, and keep patients on it, and hopefully keep patients off dialysis. And I think the one thing I would say is that we're really bad as nephrologists, and I have to always look at the cardiologists. They're far better at doing things. You know, they have their 4 pillars of managing heart failure, and they just throw them all at the patients, and they get good results. And maybe we need to think more like that. We need to be throwing more things at these patients, you know, in combination. I don't know if Will wants to comment.
Yeah, I mean, we've got some subgroup analyses where people were on an MRA and were randomized to an SGLT2 inhibitor and the other way around, and it shows reassuring, you know, safety. I'm not sure you can draw much on efficacy, but we're beginning to see the odd trial where they've randomized to dapagliflozin and plerixafor, and that suggests there's, you know, synergistic effects on albuminuria. There's the confidence trial, which is EMPA plus finerenone compared to finerenone, which will give us some really interesting information on albuminuria and on safety in combination. They're relatively small trials. I'd love to design a really big trial testing the aldosterone pathway in a group of patients on an SGLT2 inhibitor and cover people without diabetes really well. And particularly, I think, combining with an SGLT2 inhibitor, because I think most people on it will see how the effects on potassium look, because it may be that the combination actually is really ideal. So I think we need to keep doing these experiments. We've shown that we can recruit large numbers. Let's do it again and keep. What we've got. Do you think we've got 3 pillars now? Let's see if we can make it, you know, 3 really decent pillars, and maybe add a 4th too.
Our 4th pillar is our clinician, because we talk more territories. I have one question for you, Will. Actually, for myself, is clearly we've got the dual SGLT blockers, S1 and 2. Do you think they have any advantage? Apart from this, I suspect they're muted to be better at hypoglycemia effects, but do you think they have any advantage?
It's very interesting. So in 2016, I was pushing for the highest dose of SGLT2 inhibitor in our trials, and I really was excited. I also put in a submission to a combined SGLT1 T2 inhibiting manufacturer, because I actually thought, great, we could just maximize the glycosuria. It doesn't seem that you need to do that, and in actual fact, it might affect tolerability, because SGLT1 is in the gut. You can cause a bit of diarrhea. And we just don't have the data really. With one of the drugs didn't get taken forward, and sotagliflozin, we just haven't got the long-term data that shows it's effective. But to be honest, if you're in a country where you can get sotagliflozin for free and the other drugs are really expensive, you'd probably use it, wouldn't you? We just don't have the same level of information on it. That's the only case. But I think in our case, 10 milligrams of empagliflozin was well good enough. They designed it and tested it with 10 and 25 milligrams, but really 10 milligrams is enough. Yeah.
Great. Well, thanks both so much for your time. It's a couple of early Christmas presents, isn't it, for the UK kidney community. We can't emphasize too strongly, can we, how this is going to be in the implementation, and we've just got to work hard now as a community. I really like that comment of Sunil's about stripping it out and trying to present our evidence base as pillars of care for people with kidney disease. And maybe that's we can collectively.
And can I make a plug for the UK Kidney Association? Because I know there's a working group, working really hard now to review the new trial evidence. There's trials in heart failure. There's two big trials in heart failure that will be incorporated. We've got EMPA-Kidney. Sunil's working hard with the team as well. And we hope early next year to distill all this down into a simple set of recommendations for everyone, and also all the data in a larger document, so you can start to try and implement this when you've got your head around it all.
Yeah, no, that's a really crucial point, Will. And just so that people are cited on it, many of you are anyway. So I think NICE are currently evaluating EMPA, and we'll have the opportunity to comment on that as it comes out. I'm sure we'll be strong in our views, depending upon what the recommendations are. I think that's going to come out in the middle of next year. But think about what you're doing in your localities, including what access primary care have to SGLT2 inhibitors, and ensure that your locality is completely NICE compliant. I'm very minded of the fact there's also something in there for local pathways in terms of people with lower levels of EGFR. Will may want to say something very quickly about this in terms of the greatest benefit, of course, of those people who are at highest risk, and the people at highest risk are those people with the lowest kidney function, the highest proteinuria. And actually the risk with us is that we ain't going to be treating those people right at the bottom end, because we'll have some dicing and slicing going on locally where people will say, oh, NICE are actually stating that people shouldn't go on unless they've got an EGF, if the EGFR is less than 25 mil per minute. DAPA has a license, I think, down to 15 mil per minute. So you may want to think about how you're talking to people around SGLT2 inhibitors in respect of their kidney function, and doing some individual discussions with patients so patients can make informed decisions regarding the risk benefits of the treatment in respect of the EMPA-Kidney results, which Will has walked us through today. We really need to get our local pathways sorted out and get as many of our colleagues right across the board, primary care, other long-term conditions, kidney care, right up to speed on this as quickly as possible, because the numbers of patients who benefit from these results are very large indeed. Okay, well, thanks everybody. Season's greetings all, and thanks ever so much to Sunil and Will for a wonderful UKKA webinar. I think this will go up on the website for people to dip in and out of over the next few weeks or so. So thanks both, and take care now, everyone.
Thanks, everybody. Okay.